thank you everybody for joining us today on our webinar. I'm very excited to introduce Dr. Celine Saulnier today. And I'll just give you a little bit of a background, or a bit of an introduction for Dr. Saulnier. So Dr. Saulnier is a clinical psychologist by training who specializes in the diagnostic evaluation of autism spectrum and neurodevelopmental disorders. While working at Yale with Drs. Ami Klin and Sarah Sparrow and Dominic Cicchetti, Dr. Saulnier developed a passion for adaptive functioning and the implications that adaptive behavior has on functional outcome for individuals with disabilities. This interest led to a close working relationship with Dr. Sparrow on adaptive profiles in autism and, eventually, on the revision of the Vineland. Soon after Dr. Sparrow's passing in 2010, Dr. Saulnier relocated to Atlanta, Georgia, to continue working with Dr. Klin at the Marcus Autism Center and Emory University School of Medicine, the new academic home of the Vineland Adaptive Behavior Scales. So without further ado, just one other housekeeping thing I will mention actually before I pass you on to Dr. Saulnier is the chat box will be monitored by both myself and my colleague, Dr. Anne-Marie Kimball, and we will be able to take questions at the end. So please do put questions in the chat box if you have them coming up during the presentation, and we will have a Q&A session at the end as well, where both myself and Dr. Anne-Marie Kimball will be on the line and available. So without further ado, I would like to pass you over to Dr. Saulnier. So thank you very much, and I will speak with you all later.
Thank you very much, and thanks to everyone who's on the call today. I want to start by giving the disclosure that as a co-author of the Vineland-3, I will receive royalties from Pearson. And what we're going to do is go over everything that's new about the Vineland-3, highlights to what's similar to the second edition, and then what obviously is new, the new features of all the forms. I'm going to tell you about a new domain level form and our online platform, which is on Q Global, that many of you are probably already familiar with. And then we'll end with comparisons to other instruments and some of the standardization information. So first, by defining adaptive behavior. In the Diagnostic and Statistical Manual, which is now in its 5th edition, the definition of intellectual disability continues to require both deficits in cognitive functioning and adaptive functioning. And in the part of adaptive behavior, the examples are in communication, daily living, social participation, and independent living, or there's a practical domain. And then the third criterion is that the onset is in the developmental period, rather than saying in the first 18 years of life as the DSM-4 did. The severity levels, if you recall, in prior DSMs were the mild, moderate, severe, and profound levels were based on IQ score level. And now it's more based on adaptive functioning level, which is really more meaningful because this is what makes a person independent in their daily life. So once we can define intellectual disability, then we can differentiate IQ from adaptive behavior. And if we consider cognitive ability as your repertoire of skills that are, by whatever definition used for cognition or IQ, is innate or acquired, skills that the individual is capable of performing, so their optimal performance. Adaptive behavior is more the skills that are applied, those repertoire of skills that are applied for necessary personal and social sufficiency. So these are skills that the individual performs independently across daily activities and routines without prompts, supports, or reminders. So not the repertoire, but the application of skills to real life. The characteristics of adaptive behavior are that it's age-related. So as an individual ages, they're going to have a more increased repertoire of adaptive behavior skills. Adaptive behavior is defined by the expectations and standards of others. And since we live in a social world, this is predominantly social. So these expectations are to interact and engage with other people. Adaptive behavior is defined by typical performance, not ability. So again, not the repertoire skills, but the actual application of those skills to daily context. And adaptive behavior is modifiable, and this is what makes it very different from the definitions of IQ or cognition, which are considered to be more or less stable across the lifespan. Whereas adaptive behavior, you can change. You can change it through treatment. You can change it through environmental changes, thinking of a person going from a disadvantaged community to a more advantaged community. And certainly trauma or injury can impact adaptive functioning. And then adequate is the appropriate goal in adaptive behavior. You don't want to be advanced in adaptive functioning. For example, you don't want a very young child going out independently at night with groups of other people. So to give you a bit of history on the Vineland, I'm not sure why the screen is coming up jumbled like this, so I apologize for that. But Edgar Dahl developed the original Vineland, which back in 1935 he developed the Vineland Social Maturity Scale. And this was named because he was working at the Vineland Training School in Vineland, New Jersey. And in this era, this is when IQ tests were being developed, and really it was a very popular craze at that time to test IQ, to assess for then mental retardation, or what it was called feeble-mindedness. And that became, the whole same time as the eugenics movement and sterilization and all that black time in our history. There were clinicians such as Edgar Dahl that believed that we really need to assess IQ more than just by cognition, and that he really talked about social competence in this regard. So when developing the Vineland Social Maturity Scale, it really was encompassing social competencies in addition to what we now consider daily living skills, self-help, dressing, eating, bathing, but also communication and socialization and motor skills. Dahl was the first to say that the measurement of adaptive behavior really needed to be by a third party, meaning that the individual with the disability themselves likely didn't have the insight or awareness to truly be assessing their own level of functioning. So a parent or caregiver, rather, could give the most accurate information, and this was best assessed through an interview, an open-ended interview. And there is a quote here that I apologize gets cut off, but no mental diagnosis is complete if it does not begin with a sound estimate of social competence and end with a prediction of social competence following I believe it says, the evaluation. And so Edgar Dahl really was thinking more broadly and comprehensively about adaptive behavior. So in 1984, the very first Vineland Adaptive Behavior Scales was developed by Sarah Sparrow, David Balla, and Sarah's husband, Dominic Cicchetti. By this point in time, the U.S. laws had already defined adaptive functioning in the Education for All Handicapped Children Act of 1975, which is now what we know of as the Individual with Disabilities Education Act, or IDEA. And this was saying that it's part of the definition of intellectual disability to also have adaptive deficits. So a standardized measure truly of adaptive behavior was needed. So Sarah Sparrow expanded upon the Vineland Social Maturity Scales, focusing on all broad areas of adaptive functioning, not solely on social competence. And similar to Dahl, Sarah Sparrow endorsed the third-party administration, emphasizing the most reliable method of obtaining accurate information on adaptive behavior was through the third-party interview, an open-ended clinical interview. So there are many uses for the Vineland. Many individuals use the assessment to confirm or establish intellectual disability because of the definition of adaptive deficits. The diagnosis of autism spectrum disorder, which is my area of expertise, it is becoming more standard practice to have a measure of adaptive functioning as part of a diagnostic evaluation. And skipping to the bottom bullet point here under research, if we have a grant that is funded by the National Institutes of Health, there is a national database for autism research where there are required measures for doing a diagnostic characterization for autism when you're conducting research. And the Vineland is the chosen measurement, and so it's modeled in NDAR. Excuse me. And then certainly we use the Vineland for IDEA evaluations in the schools, It's incredibly useful for program planning, and then of course to measure progress or change because adaptive behavior is so modifiable. So now I want to highlight all of what's new with the Vineland-3, and we will go over this in much more detail. But I do want to show you here that we have the very same interview, parent, caregiver, and teacher forms. So the 3 main forms stay intact. But now we have comprehensive and domain level. So starting with comprehensive, this is just your tried and true Vineland that you know of in its 3rd edition. The domain level is a new, briefer administration of the Vineland if you just want to do a quick assessment for eligibility. So I will get into more detail on domain level forms later on in the webinar. So we still have the major domains and subdomains intact, same as the Vineland-2. However, the motor domain is now optional, which I'll talk more about in a little bit, and the motor domain now goes to age 9. So the norms are extended up to age 9, even though the entire domain is now optional. You still get an overall adaptive behavior composite with both the comprehensive and domain level forms. And the ages continue to be from birth through 90 plus years for the interview and the parent caregiver forms. The teacher form is from ages 3 to 21 years. If you knew about the total item counts in the Vineland-2, there are actually more items in the comprehensive interview and parent, caregiver, and teacher forms because we combined the survey and expanded forms when we were doing the development of the Vineland. So we had more items in our pool to choose from. But because of Basil's and Ceilings and because of the new online administration, it still is it's a more quick administration time across the forms in comparison to the Vineland-2. So what's not changing? As mentioned, the 3 forms stay intact, interview, parent, caregiver, and teacher. However, we remove the word rating, and we also remove the word survey from survey interview because we combined survey and expanded. We removed rating from parent, caregiver, and teacher forms. We have the 4 adaptive domains: communication, daily living, socialization, and motor, with motor domain being optional and extended to age 9. And the 11 subdomains with gross and fine motor being optional. The maladaptive sections are still an option in the administration, and they are now included in the parent, caregiver, and the teacher forms. And now they're internalizing, externalizing, and critical items. We removed that section that was called Other in the Vineland-2. So within the communication domain, receptive, expressive, and written communication remain the subdomains. So receptive communication, what an individual understands. This is both speech and nonverbal communication, so gestures, eye contact, things like that. Expressive communication, what an individual says. And in the manual of the Vineland-3, there will be a statement that qualifies, in addition to speech, if an individual uses sign language or any other form of augmentative communication, such as a voice output system, for example, that this counts as expressive communication, or even receptive communication and responding. Written communication, what an individual reads and writes. The daily living subdomains are personal, domestic, and community. So in the personal daily living skills, this would be eating, dressing, toileting, bathing, etc. Domestic would be your household tasks. In the teacher form, however, we changed this to numeric rather than academic, because if you remember the specific items in the academic subsection of the teacher form of the Vineland-2, most of those items were related to mathematics. It would be counting, identifying time concepts, and things like that. So we just renamed it numeric. The community daily living skills, this is how an individual functions in the world outside of the home. So obviously in the teacher form, this would be considered school community. In the socialization domain, we have interpersonal relationships, play and leisure, and coping skills. so interpersonal, how an individual interacts with others, play and leisure, how they play and use their alone time, and then coping, how an individual regulates their behavior and demonstrates responsibility to others. So the motor skills domain, now optional. I should qualify that if you choose to give the motor domain, the scores are not included in the adaptive behavior composite. So the ABC will still solely be communication, socialization, and daily living. But it still has gross and fine motor, so gross motor using your arms and legs and big movements and coordination, and then fine motor using your hands and fingers to manipulate objects. So the motor skills domain is normed from birth to 9 years, so you can administer it and obtain age equivalent scores at any age if you are assessing that specific area. For example, this would pertain to many of you being occupational therapists. When you have an older individual, say a 15-year-old, who you know has motor impairments that you want to highlight, you can certainly still administer. So the maladaptive domain, again optional for children over the age of 3. It's measuring undesirable or atypical behaviors that interfere with adaptive functioning. So rather than measuring the absence of an adaptive behavior, it's really measuring what's atypical. So a lot of these items you will see are almost symptoms of another disability in the DSM. Similar to the Vineland-2, you administer all items in the maladaptive domain if you're choosing to give it. And the 3 areas, as I mentioned, internalizing, these would be your anxiety, depression type items, your externalizing, hyperactivity, more aggression, disruptive behavior, and then the critical items would be things like self-injury, suicidality, and really severe aggression. Okay, so to highlight what is new with the Vineland-3, and I'll go through these in subsequent slides, we updated the item content to make the Vineland current. We have the new online administration on Q Global. We have the tried and true comprehensive forms with new brief domain level forms. When we talk about the reports that come from administering a Vineland, we have item level comparisons now and a new intervention guidance. So starting with updated content, items were updated obviously to reflect changes in our lives, such as technology. We tried to be very broad with the terminology of technology rather than specific types of technology, for example, like a tablet or an iPad, because those could quickly become outdated, as you could imagine. And we really tried to be conscious of conceptions of developmental disabilities such as autism. We dropped any outdated items or modified them to be more current. And we used more general wording to allow for potential cultural differences, such as, for example, understands what direction his or her language is written in rather than saying can comprehend the written text left to right, for example. Responds politely when given something is more general than says thank you. So these we're hoping that makes the Vineland a little bit more universal, though it's almost impossible to make it completely universal across cultures. And then we did reduce redundancy by streamlining similar items to specific subdomains. So if you recall on the Vineland-2, there were conversation items in both communication and socialization domains, so we moved them all to socialization. So examples of updated content within the receptive subdomain, we included more items at all developmental levels, so really trying to pad items on the older end, and then also included items about nonverbal communication, gesture use, and things like that. We have expanded the written subdomain to include more items at all developmental levels. So for example, pre-reading and pre-writing skills, as well as more advanced skills for the older ages. Within the personal subdomain, we added items to reflect healthy eating habits and healthy exercise choices, not only showing awareness that it's important to exercise and eat healthy, but also taking the initiative to make these choices and actually do it. And then we updated the community subdomain to reflect the use of technology for everyday purposes. So for example, using the internet to obtain information more than just, for example, going to the library. And we added items in the coping subdomain to better assess social gullibility, because this is so critical to disabilities such as intellectual disability and autism. So for example, understands that a friendly appearing person may actually intend harm, or recognizing that advertising messages may not be accurate. So more like perspective taking and theory of mind, and really making sure that we are being conscious of potential gullibility. We also made some changes to the Basil and ceiling rules. And when we talk about the online administration, this will make more sense. But within the interview form, we still have a Basil of 4 consecutive scores of 2 and a ceiling of 4 consecutive scores of 0. And then in the parent and caregiver and the teacher forms, we now added Basils and ceilings. So the Basils are 5 consecutive scores of 2, and the ceilings are 5 consecutive scores of 0. Now the reason for doing this is because of the ease of online administration, where the Basils and ceilings are calculated by QGlobal, so that it takes all of that out of the examiner's responsibility, and it makes for a much quicker administration. However, if you do choose to still use the paper form, then you will have to account for the Basils and ceilings, and in future slides I'll show how that is done. We changed the item scoring. So in the Vineland-2, a score of 2 is usually, a score of 1 is sometimes or partially conducts the behavior or performs the behavior, and a score of 0 is never performs the behavior. So the big change in the Vineland-3 is that a score of 1 is only sometimes performs the behavior with independence and without reminders. And the reason we did this is because partial performance of a behavior to us is not independence. So to really be a true adaptive behavior, it needs to be the full behavior. So the sometimes means sometimes performs the full behavior. Within the maladaptive domain, the score of 2 in the Vineland-2 was usually, we just changed it to often, because it was just more intuitive with the way those items are written. So again, the rationale for removing partially for a score of 1, sometimes with independence versus partial independence, that we really want the entire behavior to be performed. Keep that in mind, though, if you're still administering some old Vineland-2s versus the new Vineland-3s, to make sure that you're cognizant of that difference, so you don't break standardization of the Vineland-2. In the Vineland-3, we added the estimated items. So in order to do this, we removed those options for don't know or no opportunity. And if you recall, the Vineland-2 teacher form already had the check if estimated response for every item, so we just used this approach across all forms. And the rationale here is that a very familiar respondent educated guess is highly likely more accurate than an assignment of don't know or no opportunity, which was given a score of 1 in the Vineland-2, which is giving them credit if the educated guess was that they really do not have that skill, or not enough credit if the educated guess that they do have the skill. So here is what it would look like on the form. That here is your response, and you can check if estimated. However, as you would imagine, if you estimate too much, it will render the administration invalid. So down here you can see that if 2 or more sections of the form have more than 25% estimated items, then it could be invalid. So use this metric here as whether or not you want to determine if those domains are valid. And then it's the percent of estimated items per section is the number of estimated items divided by the total number of items that were answered. So right now we're going to focus on the interview form of the Vineland-3. So the Vineland-3 interview form remains the leading measure for assessing adaptive behavior. So going back again to Dr. Sarah Sparrow and Edgar Dahl, who believed that the semi-structured interview between a professional and a caregiver provides the most accurate and comprehensive information about an individual's adaptive functioning. And by this open-ended interview, you're probing for information and you're gathering information that's much more comprehensive than the item itself. And so this really informs not only the interview, but how you might make recommendations for treatment and intervention for that particular individual. Now, adaptive behavior is not capacity or repertoire of skills. It's the independent and functional application of those skills to daily contexts and routines. So think of this as differentiating the can-do or ability from the does-do. So when you think of giving a rating form to a parent, and you give the instruction, I don't want you to rate these items based on what your child can do. I want you to focus on what he does do with independence, without reminders, etc. You can give that instruction 5 times to a parent, and by the time they're on the 6th or 7th page and 150th item, they will default to the can do, because they will be thinking, does my child do this? Yes, I think he can do that. But in an interview, a clinician can probe further and say, oh, you just said that your child can dress himself. Well, what percentage of the time does he fully dress himself without any reminders or prompts from you? And then the parent will say, oh, maybe about 20% of the time if I don't remind him. Well, that's a very different score of a 0 or maybe even a 1 versus full credit. So what can happen by giving a rating form versus the comprehensive interview is that you get inflated scores of adaptive functioning. This might not be problematic in typical development, nor might it even be problematic in some disabilities. But for autism, it is very problematic because many individuals, certainly those with higher cognition, they have a significant gap between their repertoire skills and what they functionally apply with independence to real life. And that actually results in very limited independence into adulthood, and it's poor outcome. And so we definitely want to make sure we're assessing adaptive behavior accurately so that we can maximize optimal outcome. So we want to really make sure we're differentiating the can-do from the does-do. In the interview, because it's semi-structured and open-ended, it's not intended to read every item to the respondent. So you really just should be using open-ended questions such as, let's talk about Johnny's speech, and rather than how many words does he have. So there are interview guidelines, and in the Vineland-3, you will see these both in the booklet form and in the online platform, and we'll talk about Q Global in 1 second. But you will have the topic area, which in the Vineland-2 and the booklet, there were symbols to designate each topic area. So friendships, dressing, bathing, etc. would be a different symbol. Now in the Vineland-3, it's just letters designate the topic area, not symbols. Then there's a suggested interview question now. So an open-ended question to help elicit information on a given topic area. So for example, tell me about Stella's friendships for the topic area of friendships. And then we also added item-specific probes to get at a specific item in more detail. So how does Stella try to make friends with others her age would be an example. And then scoring criteria. The manual will have the scoring criteria for every item, as well as the suggested interview questions. However, there is a booklet form that you can choose to purchase that will have the item-specific probes written directly underneath the item itself in blue, so that less experienced interviewers can have that as an aid to help them with the interview. So if they're asking open-ended questions and not closed-ended questions. And these are for optional use. Certainly more experienced interviewers just are used to giving the Vineland would not need these specific probes, but they're there for the less experienced interviewers, people new to the Vineland, and they're not intended to fully script because remember, it is supposed to be an open-ended, semi-structured interview. So now let's talk about what's new on Q Global. So Q Global will be an option for all 3 forms and for both the comprehensive and the domain level forms. So Q Global will provide the items by topic area right on the screen, and I will show you a sample screen on the next slide. And it will keep track automatically of the basals and ceilings as well as calculating the score. So that takes all of the pressure off of the examiner to have to do that as they are administering the interview. And then Q Global is also conveniently organizing items by topic area. So when you're using the paper form, you would have to find all the similar symbols that designate the topic area of friendship, whereas on Q Global, only those items related to friendships will come up on the screen at one time. An interview topic can include anywhere from 2 to 6 items at a time. So if there are multiple items on friendships, for example, maybe 2 screens will come up subsequently. And based on the item responses, the next topic will be generated in order to establish the basal or ceiling. If you need or would like training on the Q Global platform, then you can go to pearsonclinical.com, and there are trainings here. And I believe the next one coming up is on September 20th. So here is the sample interview topic screen. So first you see here the topic is within the subdomain of interpersonal relationships is friendships. You have your suggested interview question, tell me about Stella's friendships. You have the items listed here, your response options, usually, sometimes, never, and your check if estimated. Down here you have a place to write all of your behavioral observations just as you did in the old paper form. And then if you click on probe, the item-specific probe will pop up that is printed in the actual paper form. And then if you needed the scoring criteria, you could click here and you will get the additional scoring criteria that's provided in the manual. And again, this just highlights the different features of the topic areas and the item-specific probes. I should say that when you are on the Q Global platform, if you're not familiar with this, it is when you are actively online. So if you lose internet connection or if you had to stop the interview for any reason in time, it saves as you go. So the next time you log on, it will just bring you right back to where you were when you were interrupted. So items with and or similar to the Vineland-2. If you have items with and, so for example, sets a short-term goal and achieves it, then each activity must be performed without help or reminders to receive full credit. Whereas items with an or, so for example, watches or listens to TV or radio or uses the internet to obtain information, then either activity must be usually performed without help or reminders to receive full credit. Within the maladaptive behavior domain, we have internalizing, externalizing, and critical items. And again, I should highlight this is just a brief assessment for problem behaviors. If this is the focus of your assessment, you would be using additional, more comprehensive measures for these problem behaviors. Now that the maladaptive behavior domain is an option for the parent, caregiver, and teacher forms in addition to the comprehensive interview, then these sections are labeled as A, B, and C rather than internalizing, externalizing, critical, so as not to inadvertently influence the responses. And again, these domains are optional over the age of 3. The internalizing and externalizing sections yield a V-scale score with a mean of 15, standard deviation of 3, though the critical items do not generate a scaled score, as this is not a unified construct. They are just items representing a whole variety of things. And then we change the score of 2 to indicate often rather than usually because, as I mentioned, this is just more intuitive of the frequency. So now let's talk about the Vineland-3 in the parent, caregiver, and teacher forms. So the online administration of the parent, caregiver, and teacher forms can be conducted using Q Global on a computer, on a tablet such as an iPad, or even on a smartphone. I should mention that the comprehensive interview can only be conducted on a computer or tablet. That cannot be conducted on a smartphone. But the parent, caregiver, and teacher forms do have the option to be conducted on a smartphone. So Q Global will be sending the email to the responder, whether it's the teacher or the parent or caregiver. So that's not coming from you, the clinician, with your email address or personal information. It's coming generated directly from Q Global. They click on a link and they can answer all of the items sent to them. The forms can be completed, as I mentioned, in one session or in multiple sessions. So changes that we made to both the parent, caregiver, and teacher forms was the introduction of Basil and ceiling rules. So as I mentioned, the Basil 5 consecutive scores of 2 and the ceiling 5 consecutive scores of 0 that are generated automatically through the use of the Q Global platform. This significantly reduces the administration time of both forms. However, if you were going to use the original paper form, then you as the examiner will need to carefully prepare the test booklet to ensure that the required items are completed. So things to help ease in this are to clearly cross out the sections not to be completed. So for example, based on the age, if you know that the written subdomain is not prior to age 3, you'd cross out those items. Or if you don't want to give certain things, cross them out. Then circle the start item, whether you believe it to be the chronological age or the mental age, whatever you as the examiner decides, that's the start item so they know at what point to start. Changes to the teacher form that we made. This is actually the least changed of all 3 forms relative to the second edition. The maladaptive domain has been added to assess problem behaviors in the school setting. The motor domain is optional as with the other 2 forms. And the teacher form is at a 7th grade reading level. As with the Vineland-2, the test range is ages 3 to 21, with the norms for the norms for the 19, 20, and 21-year-olds are the 18-year-old norms, and that's because for typical development we didn't have access to 19, 20, and 21-year-olds in the school system. Changes to the parent-caregiver form. We separated the interview from the parent-caregiver form. So if you are familiar with the Vineland-2, those are identical. The items in the parent-caregiver form and the interview form are identical. So in that case, the Vineland-2, those were normed together. What we ended up doing was, because parent reading levels are usually lower than examiners or clinicians administering the interview, we changed the content. We changed the wording of each item so that it is at a lower reading level to achieve a 5th grading reading level overall across the entire form. The content, however, is identical. So if you look at the 2 items, it's the same content that we're assessing, but the wording is different. Because the wording is different, we had to norm the 2 forms separately. So there are differences between the 2. And now it is the parent-caregiver form that's available in Spanish for both the comprehensive and domain level forms, whereas the Vineland-2, the Spanish option was the interview. But because many examiners who are conducting the interview with a Spanish-speaking family are bilingual, the interview is also by nature an open-ended interview that's not scripted, so there was no way to script that in Spanish. So the comprehensive interview online and in paper form is still in English. It can be conducted in Spanish, but the examiner will just be answering the responses, scoring what the informant says on an English form online or in paper. But the parent-caregiver form that you are actually handing to the parent, that is now in Spanish. So how do you choose between giving the comprehensive interview versus the parent-caregiver form? advantages of the interview is, as I mentioned, it protects against really having an inflation in scores if that's the potential for not differentiating between the can do versus the does do. It also could eliminate any discrepancies that result from misunderstanding the item content or the scoring rules. Or some parents, whether it's conscious or not conscious, they could overreport or underreport for certain reasons. And the interview just takes away all of those potential biases. You're also, as I mentioned, getting more in-depth and comprehensive information regarding the overall level of functioning of the individual that you wouldn't get just by a rating form in and of itself. However, the advantages of giving the parent questionnaire is that it's a valid and reliable assessment of adaptive behavior when a face-to-face interview is not possible, and it also allows an option for Spanish-speaking families. So now I'll talk to you about the new domain level forms. So the domain level forms, as I mentioned, offer a brief administration. This is across all the forms: interview, parent, caregiver, and teacher forms. And it will provide scores for the domains only, so communication, daily living skills, socialization, and optionally for motor and maladaptive behavior. And it will also provide an adaptive behavior composite, but it will not provide you the subdomains, so receptive, expressive, written, etc. How we established and developed the domain level forms are that we sampled items across all the subdomains. So communication, for example, is a sampling of items from receptive, expressive, and written. We sampled across developmental levels and across the subdomains, so that when you have a very brief administration, we are hoping that we are getting still a comprehensive view in that we're crossing all of the content of the subdomains without having enough to give a specific subdomain. And the timing is much quicker. So as you can see here, that when we give the domain level form, it's a much briefer administration. And the ages are 3 to adult because the primary use that we intended for the domain level forms is for eligibility. And we're really not determining eligibility, for example, for intellectual disability in a child under the age of 3. There are no Basil and ceiling rules because you are administering every item because there's so few items. So per domain there might be about 45 items. So now I'll talk about the reports. So, and I apologize again that this, if you're seeing it this way, that it's jumbled. But everything that was offered in the Vineland 2 as far as the computer generator reports is still available in the new Vineland 3. So you will still have access to all raw and norm reference scores, to the narrative text describing the scores, to both the multi-rater and progress report comparisons for the interview, parent, caregiver with the teacher forms. But now we are also including item level comparisons as well as a new intervention guidance that I'll talk about. So when we're comparing results between the interview or parent caregiver and the teacher forms, we're doing this so that we can really obtain input across different contexts, because this is the ideal way, this is best practice when conducting evaluation, that you want input across settings. As a clinician or an examiner, you're using your judgment to interpret any differences that might arise between the informants. So just because a parent provides a different view of a child in the home and community context than a teacher does in the school context, that doesn't necessarily mean that one's right and one's wrong. Certainly, a child with a disability can present very, very differently across contexts. So for example, in autism, they might present much better in the highly structured, routine, and familiar teaching environment where expectations are very clear and predictable, whereas in the home environment, things are less predictable and often more chaotic, so they might present worse in the view of the parent or caregiver. Or it might be vice versa, because a child performs much more, better when they're in a highly familiar environment with people they know and trust, whereas when they're in a school or a stressful environment, they might present worse. So this gives you the opportunity to have those comparisons. So if we look here, the Vineland-3, same as the Vineland-2, is going to offer this information either in a table form or in a graph form or both, whereas you have one respondent here, the parent, one respondent here, the teacher, and here are your domain and subdomain forms as well as your maladaptive section. And you can see here the discrepancies across respondents. And then you can use this information to interpret why there might be differences there. But now you also have item level comparisons. So parent and teacher again, but this time you can specifically see, well, it's body parts specifically that they're doing in the home but they're not doing in the school. And this really can inform intervention quite well, because now you're getting at a specific behavior. And then we have the same for progress monitoring. So instead of 2 informants, we have 2 points in time. And this, the Q Global will enable comparison of results from up to 5 different administrations of the same form or same format. And you can compare over time for the comprehensive or domain level versions of all the 3 forms. However, you should not be making comparisons across the formats, because these differences could obscure the actual behavior changes, the difference in the actual the way they were standardized. So here's an example now using the graph, that here you have your time 2 and your time 1, so you can see progress made in the domains and subdomains, and then now new in the item comparisons. So this is, again, really informative to track progress versus any potential loss in a previously acquired skill. When you see an asterisk like you do here, that would be items that were below the Basil or above the ceiling, and so these you would pay less attention to because you were not directly assessing those behaviors. And then we have new intervention guidance that's generated for the comprehensive forms only, because it's really drawing upon those subdomains that have the lowest V-scale score. So really identifying the areas that are of the greatest weakness for the individual assessed. And then so when you look in those subdomains that have the lowest V-scaled score, all scores of 0 and 1 can be referenced to the normative expectations or to the expectations of that particular individual based on their mental age, and prioritized for intervention. So this is easier to see in chart form. So the lowest subdomain score for this particular example is the written subdomain of communication. And you can see here are the scores. So what we're really looking for here, what was 0 and even what was a 1 if we're expecting full independence. And then the letters here designate the content area. So you can see within the zeros, for example, there's lots of C's. C is the content area of developing writing skills. So that can be directly translated into an IEP as a goal or objective to work on writing skills for this individual. So now we'll end with talking about the psychometrics of the Vineland-3. The clinical samples included in standardization included developmental delay and intellectual disability. Our ID sample, we had a school age and an adult sample, and then we segmented by IQ below 35, 35 to 49, and 50 to 70. And then we also had autism spectrum disorder segmented by age and by IQ, because people with intellectual disability and autism present differently than individuals with individuals with autism without intellectual disability, and then the hearing and visually impaired. So comparisons to other measures of adaptive behavior, the Vineland has the longest history dating back to 1935 in the Vineland Social Maturity Scale. It is by far the most researched measure of adaptive behavior. It's used in research worldwide. In the field of autism, it's certainly the most researched, knowing that we have now profiles of adaptive behavior in autism. And in the original Vineland, there were norms for autism. And the Vineland-3 now offers the most options for tailoring to meet your individual needs. So we have the interview, parent, and teacher formats, all three in either the comprehensive form or the briefer domain level formats, and the option for all three to be either online administration or the original paper administration. And then finally, the Vineland-3 has the most up-to-date population represented norms. And when we look at these norms, in the blue we're going to have race and ethnicity, and in the purple we will have our measure of socioeconomic status, which is predominantly maternal education, but in the cases that that wasn't acquired, it would be paternal education. And you have here for all three forms, the first number designates the statistics for the Vineland-3 standardization sample, and in parentheses would be the U.S. Population norms. So you can see that there is high consistency for both race, ethnicity, and socioeconomic status across all three forms. So it was very well standardized in close proximity to the U.S. Census. Now this chart is showing you the internal consistency. So the reliability for now the blue is the comprehensive forms, and the purple are the domain level forms. And you can see that for across all forms there's very high reliability, with the only one score falling below 0.9. So with that, I hope that you have learned quite a bit about the new Vineland-3 and that you're as excited about it as we are. And since we have time, we can open it up to some questions for anyone who might have them. So thank you so much for your time and attention.
Thank you, Dr. Saulnier. That was really, really interesting. I really enjoyed listening to that. I find it fascinating. If anybody wants to type in any chat questions into the box, then I can ask them now. If we don't get time to cover them, then we'll make sure we get back to people with an answer after the presentation. I do have a couple of questions that have sort of come up while you've been talking. One of them is, can you explain a little bit about, can we use the Vineland for working with other groups other than those with autism? And are there any particular groups that sort of spring to mind as being appropriate for using the Vineland with as well, or is it,
Oh, sure. I would say with any disability, I think the Vineland is universal in that regard because it's about functional independence. So with any disability, that's what we want for the individual most, right, is to be a functional independent adult, to live independently, to be able to hold down a job, to be able to, get along in life socially and function independently with others. So in that regard, adaptive behavior has been researched and used clinically across just about every disability. There are profiles of adaptive functioning based on Vineland research with not only autism and intellectual disability. Those might be the two of greatest focus, but certainly of genetic disorders, Fragile X syndrome or Williams syndrome, or other disabilities, ADHD, profiles in ADHD or learning disabilities. So absolutely it's something that we would want to assess for any individual if we're thinking that they're lagging behind in their adaptive behavior.
Excellent. Oh, excellent. Thank you very much. That was really, really helpful. Okay, another question that's come up from an individual who is new to, hasn't used the Vineland previously, but has asked, would this be something to be used in private practice versus the school setting, and do insurance companies recognize the use of the Vineland? So it's kind of
yes, we actually we use the code. I wish I could rattle off the codes. I'm not good with CPT codes because I work primarily in research where we don't have to use them. But the 90601 or something of that regard we use as part of the clinical assessment, and the Vineland is included in that assessment. And so we would use it clinically. So for example, if we're doing an evaluation, that we might do a Vineland with a parent, but also send out a Vineland for the teacher, which in this case, now that it's an automated email that could go right to the teacher, we'd probably get a better response rate than we do when we've mailed the paper form with a return stamped envelope and hope for the best that they'll mail it back. But absolutely, we could gain the information both from the parent or caregiver and from the teacher as part of our evaluation. Whereas in the school setting, they're doing it just specific to their context, and they may or may not also conduct an adaptive behavior measure with the parent. So I think it's just as useful in either setting.
Okay, wonderful. Thank you. Okay, another question. Would you say that the Vineland can be used for measuring small increments of change over time? And do you have anything to sort of comment on how it can be used for measuring small increments
Sure.
of change?
Because it's so modifiable, we've used the Vineland in clinical trials, and there are now more and more publications coming out using the Vineland as a measure of outcome. So one in particular, there was the largest randomized controlled treatment trial using parent training for autism rather than a pharmaceutical like a drug. And secondary to the actual parent training, the manualized parent training improved behavior. So it was really targeting problem behavior in autism. But a byproduct of that treatment was that adaptive behavior increased, most significantly in daily living skills, but also in socialization skills, which is a core impairment in autism, and that was within a 16-week trial. So we saw significant, actual statistically significant improvements that were also clinically significant within 16 weeks' time. So I absolutely, to use it for monitoring progress, I think is fantastic.
Excellent. Thank you very much. Okay, another question, and as you're not an occupational therapist, I don't know how well you can answer that, and maybe I can contribute to this one. But this one is, what is the history of the Vineland's use in the field of occupational therapy? Is it commonly used in the school system? I don't know if you're able to answer that one, as you don't work directly in the field of occupational therapy.
Right, exactly. But in my own experience in multidisciplinary evaluations, sending test results to an occupational therapist and chatting with them over the phone and saying, okay, these are the things that we did. So for example, if I, as a clinical psychologist, conducted developmental assessment, and my developmental assessment has motor, but really a broad fine and gross motor subscale, then I conduct a Vineland. Now I have the parent's report of fine and gross motor. I can make the comparison of those two. Did my direct assessment coincide with the fine and gross motor skills reported in the home? And if not, then I have to come to terms with interpreting those discrepancies. But an occupational therapist is going to really delve into the fine and gross motor much more comprehensively than I would as a psychologist or the parent would with the rote assessment on the Vineland. So I would use it as almost like a broader assessment, and then to the more comprehensive assessments that are conducted by OTs. But certainly you're getting that parent report perception of very similar behaviors. I think when we think of communication, for example, and we're thinking of a speech pathologist, the Vineland communication items are conceptually different than standardized items on a speech, language, and communication assessment, because the same way cognition is different conceptually from adaptive behavior, so would standard speech language assessment constructs be from the communication constructs on the Vineland. But I have to say the motor items, they're conceptually very similar, because motor is motor, right? So I think it's just really, are they producing the skill in real life context is the differentiation there. It's still the same behavior. So the OT can really get at those behaviors much more specifically, but it's very good to still have the parent perception.
Yeah, and I know we're just coming to the end of time, but I would also add to that as well. It certainly is a great way of getting the parent and the teacher perception, which I think is crucial to what we do as OTs. And also, in my experience of working with Pearson for many, many years, 15 years now, I've certainly spoken and worked with many OTs over the years that do use the Vineland and use the Vineland very successfully for giving that broader picture, and then they can sort of delve in and look at things in a little bit more depth, just as you've sort of described as well, and for getting that parent and teacher perspective. So I know over the years it is very well used amongst occupational therapy practitioners, not just in North America, but in other parts of the world as well. So
right, and not to mention, a lot of the developmental assessments have motor, but IQ tests don't. You would have to really get into more neuropsychological assessments and or have a specialized OT eval. And so if I have, in autism, fine motor is always a deficit. So if I have a now 11-year-old that I know has fine motor impairments, but it's out of the norm range of the Vineland-3 because it's only normed to 9, I'm still going to give the domain because I want the specific items put in the IEP. So I can get an age equivalent, but more importantly, I can get those items, the content specific, and say, this is an 11-year-old that still cannot hold a pencil to write their name. So to highlight that in an intervention program, I think is critical.
Exactly. Fantastic. Okay, I've noticed we've run over time by 2 minutes, and there are no further questions pending. So I think at this point I will thank Dr. Saulnier for a wonderful presentation. Thank everybody for listening and for asking questions. And if you do have any further questions, please do contact us, and we will be making this recording available, so it will be available afterwards, and the handout, etc., will be available. So, and I think that's it. Without further ado, I will sign off and say thank you and enjoy the rest of your day, everybody. Thank you very much. Okay.
Thank you,
Bye-bye.
everyone.